So friends, as promised, the first seminar which I'm bringing across for 6 Minute ICU program is Thromboprophylaxis in Medical and Intensive Care Unit. Now, you would say that why am I even talking about this? The reason is that I start off with the principle saying that unless contraindicated, all patients should receive thromboprophylaxis in intensive care unit. Now, I'm going to try and see if I can get this concept across to you in the next 6 minutes or not. First and foremost, the patients who are critically ill have got a 75% fatality in medical hospitalized ICU patients if they have a VTE while they're in the hospital. They have a 2 times higher risk as compared to the general ward patients, and you seem to see a 33% high incidence of VTE in critically ill patients. Now, what's the problem? The problem is that we are detecting only 1/3 of them. The rest of them were based on autopsy findings, and how we know in India how poor we are in doing medical autopsies. Also, we need to understand that it not only adds on to the mortality, but those who survive have an increased duration of mechanical ventilation, length of ICU stay increases, and so does the mortality. So what's important? It is the single most preventable cause of death in critically ill patients. So let's have a closer look at this. Well, there are lots of scoring systems. The Wells score, if it's greater than 2, the PODA score, if it's greater than 4, the Geneva score, if it's greater than 8, all of them point towards a high risk of VTE. We also know from this study here that if you have got infection in a hospitalized patient, the risk of venous thromboembolism increases to almost 48%. The ENDOS study looked at exactly this point. They saw approximately 1,000 odd patients, 680 in surgicals, 400 odd in medical wards, and they found that only a fraction of them, less than 1/3 of them, received thromboprophylaxis, and it was a major underutilization of thromboprophylaxis to the tune of only 17%, where the global average was around 50%. We know from the PGI Chandigarh study published almost 14 years ago that there is an incidence of thromboembolism, specifically PE, detected on autopsy in around 16% of the patients, and contribution of pulmonary embolism for death was in the tune of 80%. Now that's humongous. We cannot really ignore that. The next thing which we look at is another big institute, CMC Vellore, reporting an incidence of venous thromboembolism to the tune of around 17.5 per 10,000 admissions in ICU. AIMS data was similar. AIMS data sort of looked at an increased incidence of VTE in the ICU patients who were admitted to the ward as well as in the ICU, and only 2 of them received thromboprophylaxis within 2 days of their admission. Now, there's a DETECT study done by our very close friend, Naresh Ramakrishnan. He looked at patients who were admitted in the hospital in the ICU, and he found that only 44% of them actually received some thromboprophylaxis. 55% did not receive anything. Now, this chart here tells the story. The right one shows you that people who did not develop DVT, but the people who did develop DVT, all of them were in the group where thromboprophylaxis was not given. So every time it's pointing out to the fact that you need to give thromboprophylaxis, they are at a high risk. And why are they at a high risk? They're at a high risk because critically ill patients have got twofold risk. One, there's a general risk of venous thromboembolism, high age, a past history of VTE, cancer, immobilization, pregnancy, recent surgery, stroke. But in specifics to ICU, patients have infection, patients have respiratory cardiac failure, they've got increased use of vasopressors, they're on mechanical ventilators, they've got central line, they've got end-stage renal disease. All of these increase their risk to 2-folds as compared to a normal hospitalized patient. Hence, patients who are in the ICU are at a very high risk and should be given thromboprophylaxis. Now, what can we give and what shouldn't we give? It's very clear that you can use either a low molecular weight heparin, either unfractionated heparin or fondoperinox. For prophylaxis, there is no role for DOACs, direct acting oral anticoagulants. The ACCP guidelines, the American Society of Hematology guidelines, and NICE guidelines, all 3 of them endorse this, that for prophylaxis, you should not be using DOACs. Rest of the 3 combinations are fine. Where does this come from? The low molecular weight heparin versus unfractionated heparin. This study here looked at critically ill patients. Non-significant relative risk reduction in mortality, PE, symptomatic DVT, major bleeding, as well as hits, all in the favor of low molecular weight heparin. So low molecular weight heparin seems to be the recommendation for this. The second study here looks at the PRINCE study, the PRIME study, the Hillbaum study, the Prevail study. all of them showing a relative risk reduction in patients with VTE when compared with unfractionated heparin versus low molecular weight heparin. So low molecular weight heparin seems to be the way to go. There are at least 3 trials, the MEDNOX trial, the PREVENT trial, and the ARTEMIS trial, comparing low molecular weight heparin or fondaparinux against a placebo, all of them showing almost a 50% relative risk reduction in the incidence of VTE. So there is no doubt about it that VTE can be prevented to a larger extent, and patients who get thromboprophylaxis should be given low molecular weight heparin. What do the guidelines say? The guidelines depict the same story. ASCO, the ITAC guidelines, the NICE guidelines, the American Society of Hematology guideline, the European Society of Cardiology guideline, all of them say that use thromboprophylaxis in patients who are in the ICU. And if you're going to use them, use low molecular weight heparin over unfractionated heparin. So my key points here: VTE is the single most preventable cause of mortality in critically ill patients. Patients should be assessed for a risk stratification. They should be given low molecular weight heparin as opposed to unfractionated heparin. We also know from COVID patients, the mortality morbidity is significantly high in this age group and this category of patients. And most importantly, that within 24 hours of hospitalization, we should try and get some form of assessment and start them on anticoagulation for DVT prophylaxis. Thank you very much.